Now, in recent years, in recent months actually, the T-junction area has exploded in radiology and clinical settings. So Carl Pedret, who came up with the medial gastroc injury classification system, published a paper in November 2025, and that looked at the anatomical variation, specifically of the deep component of the T-junction. The argument was if you have a short T-junction, you'll have a shorter return to play time. If you have a long T-junction, you'll have a longer return to play time. Now, the study didn't reach statistical significance, and trying to delineate the length of the deep component of the T on ultrasound is something that I have not been able to do confidently. But there was a paper that was published 3rd of February, so what's that, four and a half weeks ago, coming out of Ireland by Cronin and Kerin, and this looked at an ultrasound-based classification system specific to T-junction injuries. So the idea is this, with this, is that you align rehab times with ultrasound findings rather than just time frames alone. So in this study, it looks at whether there is involvement of the superficial myotendinous component, the superficial part of the T. It looks at if there's a component of the deeper myoaponeurotic component. It looks at whether there's any extension into the myofascia of the short and or long heads. It also looks at the presence of an intermuscular hematoma, and it also has a particular emphasis on the dynamic behaviour under load. So if we look at another T-junction injury, I think this was post-snowboard or skiing injury, we can see again evidence of a higher grade, more chronic T-junction injury. And if we look at the still B mode, we have involvement of the superficial myotendinous component. We have involvement of the deeper myoaponeurotic component. There's extension of that discontiguity through the short and long heads of biceps femoris. So we're looking at a subtype 3 injury. There's no intermuscular hematoma that we can see through here. Now, as I said, there's a particular emphasis on the dynamic component of this injury and the dynamic application of ultrasound. Kerin and Cronin and a number of authors suggest that if you have a dissociative or asynchronous movement through the T-junction, then that's your best indicator for surgical repair. And this is the question I had to answer in this case. This was a professional rugby player. I think this was 4 weeks post-injury. So on the right of screen, we have the normal unaffected side, T-junction area, and on the left, we have the affected, the injured area. Now, you can see that there's a discrepancy between the way that these muscles move, but in my opinion, there was no gapping, there was no separation through this. This was a high-level sprinter. Again, we can see a defect through the myotendinous and the myoaponeurotic component of the T over a length of around just under 4 centimetres. And this is with fixed isometric knee flexion. So what I did better in this case is I have the T-junction more perpendicular to the beam. And again, we can see that there's no asynchronous movement. There's no gapping or separation through here. So in still, I've got a little defect of around 6.7 millimetres. With resistance, it's only around 6.8 millimetres. So according to that Kerin Cronin paper, this is an injury that could well continue to be measured or treated conservatively. Basically what I do to start with is identify the short head of biceps femoris. As I come up, this is going to be the long head through here. So my eyes are centered on the tendinous component as we work our way up. And then I try and identify that T-junction component. Again, a little bit of movement of the probe to help try and get that perpendicular to your beam. So if we just follow this muscle through here, this is that of the short head. So it's going to originate onto the linea aspera of the femur. So basically it's gone at that point. The long head will continue on. So as I come back down, we've got long head, we've got short head, and then we're trying to lie this down flat. And we can start to appreciate the T-junction through here. So the superficial component is the myotendinous component. The deeper component is the myoaponeurotic component. And this is, again, is where we're going to look. And so again, trying to delineate the length of the deep component of the T-junction is really hard on ultrasound you look at any MRI, you can do it quite easily. So with regard to the dynamic assessment of this, the idea is that there's about 15 degrees of fixed isometric knee flexion. Basically, I ask the patient to do a leg curl and resist my pressure through there. And again, what I'm looking for is any gapping or separation through that T-junction through here. So we're looking for an asynchronous or dissociative movement. So I think the boys described it as an unzippering type effect in one of their webinars as well. So
yeah, that's the idea that it looks as though it opens. So yeah, there's been some work in the sports medicine world, and yeah, particularly a lot of the Melbourne sports docs that have a bit of work to do with. They look at grading their return to play as to how much this opens up. And it tends to open from the top down. So if you get a bit of contraction and it opens up more, they're not ready to play. That's the thought process behind it.
yeah, so that paper that coming out of the Irish boys, the Cronin and Kerin as well, a really nice paper. The only thing I think with that is it would depend a lot on when you did the ultrasound in relation to the injury. So basically on all the examples I've shown, these were injuries that had occurred often a week or so after scans that occurred a week or so after the initial injury. So I think, yeah, in that case, the chance of you seeing an intermuscular hematoma is reduced, and the chance of you seeing that asynchronous movement or that separation is reduced. So, you know, I think it would be really interesting to do these scans immediately after the injury, like the 1, 2. I think you'd start to get some more of those higher grading of those sorts of injuries.
Yeah, and because it's done by the sports docs within the club, they do serial assessment of it.
Yep.
So they're having a look every second day to see how well it kind of gums up as to how quickly they can try to return them to play.
So most weekend warriors that we see, they only come in after they haven't responded for 4 to 6 weeks. And at that point, there's not going to be that acute hematoma, and you're not really going to get that separation or anything like that.